an illustration of the way it could be an interesting ventilation technique for the LMICs. Indeed, our colleague Pascal Sorohay, African biomedical engineer, will present the use of these non-invasive ventilation medical devices in CPAP and BiPAP mode in his country, Benin. So let me please introduce the Dr. Donner, which is head, which is an expert in anesthesia and intensive care medical device. I know he will, no, excuse me, I'm talking about Joel, excuse me.
Maybe I could just help you, Farid. Okay, let me introduce Adriana Velasquez. She's gonna talk to us about what is the technical specification for non-invasive ventilators or non-invasive ventilation for COVID-19. I mean, what the World Health Organization is guiding for all the world.
Thank you, Joel. Thank you.
Adriana, it's your turn.
Thank you very much. Can you let me present my screen? Thank you very much. Good afternoon, everybody. I am very happy to present to you today our next talk that is about BiPAP, CPAP, and high-flow nasal cannula. Let me put this in presentation mode. Okay. As you all know, these devices are medical devices, and they are a quite variety of medical devices. We have been talking about personal protective equipment, oxygen delivery systems, and today we will be talking about non-invasive ventilation. So what we have in the catalog of medical devices in WHO, and for every slide that I placed the link here, so when you receive the slides, you can open the links. So we have the catalog of medical devices that includes all the priority medical devices that were selected by WHO, and we select them based on the clinical management documents. And then here we have the three of them: the BiPAP with tubing and patient interfaces for adult and pediatric with accessories, the CPAP, also tubing and patient interfaces for adult and pediatric with accessories, and the high-flow nasal cannula. So the idea is that countries can go into this emergency global supply chain system and go to the catalog and then request any of these devices. And then WHO is doing the procurement for them. So what we have is we have developed the technical specifications. And so for BiPAP, CPAP, and high-flow nasal cannula, they're all priority medical devices for COVID. And here we have, they are in the technical guidance documents. Here we have, and there are different options. So the option is you have either of them, and then they are used in the second and third level. If we're talking about specialized hospital, for example, those are the ones that will be using them. And they will be used for treatment and monitoring of oxygen therapy, and also of management of severe acute respiratory infection. What is very important for the CPAP is the use of the nasal mask, the mask, and it is very important that it's very well sealed, the same as with BiPAP. And then for the high-flow nasal cannula, it is up to 60 liters per minute, and then of course it includes a nasal cannula. We have also in WHO, and I put the links here, we have the documents for clinical care for severe acute respiratory infection, and here is where you have, when you decide that a patient requires oxygen therapy, then you have the two paths. If the patient fails to respond to escalating oxygen, then you have either the intubation for urgent indications, or you use the non-invasive, so it's no intubation. And then we have the three options here, no? And these are mild and moderate hypercapnia or normal, and hemodynamic stability. No? We have also in WHO, and these are done by all our clinical experts, the cautions with non-invasive ventilation. And that specifically, this document that you can find in WHO in the link says high flow nasal oxygen should be used only on selected patients with hypoxemic respiratory failure, the same as this one. And the high flow nasal cannula should be closely monitored for clinical deterioration. And all of them say, because of the uncertainty around the potential for aerosolation, all of them should be used with airborne precautions, with further evaluation of safety. And also, it is very important to check the adequate flow, the seal of the masks, and also personal protection. So what I put here is for the three of them, they have continuous positive airway pressure. The pressures go 3 to 20 centimeters of water. And it is very important to have the seal of mask and the high flows rates of oxygen. For the BPAP, you have the two pressures, the inspiration and the expiration. There are different pressures. And sometimes you can have a helmet over the mask to protect the aerosolization to the healthcare worker. And with the nasal cannula, you have up to around 60 liters per minute. No mask needed, and it is heated and humidified. So there have been many innovations, and then everybody wants to use CPAP and BiPAP, but we want to warn you a lot. Some of these devices, they require high pressure oxygen that can come in a piped way in high income countries, but maybe not available in low resource settings. It is not necessarily appropriate for all low resource settings, and I will be glad on the next talks what we will learn from Pascal and our colleagues from France. The PPE protection is a very important one for all healthcare workers because they can get infected. So it is a high risk for healthcare workers. The mask in the patient has to be absolutely sealed. The oxygen flow has to be continuous. And there have been some innovations using scuba diving mask or others, but it is very important that the fitting does well and that the pressure is maintained and that there is an effective treatment. And many say, well, they are very inexpensive. Yes, the cost is less than ventilators, but they are non-invasive, but they need clinical management, appropriate clinical management for all patients. It cannot just be used randomly. And I just put one example. This is the UCL Ventura designed for UK hospitals, and that is exactly the word, designed for UK hospitals and trained healthcare workers. That is very important. And this has been widely disseminated. So if anybody in a low-income country wants to use it, they first need to make sure that they have all the conditions similar to the settings where these are being used today. For innovative technologies, we have placed this link in the WHO website so that you can submit your innovations here, but also check other websites that are considering innovations. And this is, for example, the submission form. And the idea is that it will be, all these innovations will be reviewed by experts group in WHO, and then the ones that are innovative and could be used in different settings will be placed in the Compendium of Innovative Technologies in about a few weeks' time. No? So with this, I finalize. I thank you very much, and I give it. I always put this slide because just procuring them or getting the innovation is not enough. We need to regulate the products. We need to make sure that there is a selection, procurement, the donations, the loan, that they are used appropriately, and the decommissioning is very important. And in the case of these three in non-invasive, the re-sterilization reuse is absolutely indispensable. Much care has to be taken. And remember, as I always say, the patient is at the end of our equipment, so we really need to manage them very carefully. With this, I thank you all. Thank you.
Thank you, Adriana. Maybe I could introduce you Dr. Gilles Donner. He's going to show you our experience in France and how he used CPAP on his experience on Paris and with the Parisian patients.
Good morning, dear all. Mr. Chairman, dear Tom Jude, thank you for inviting me presenting this short French story. And I have entitled my lecture, Chronophysiopathology of COVID-19 pulmonary infection. So please, can I have the next slide, please? So this is, I have few slides, some of them are very heavy. And let me point out for you the main step. In this slide, I detail the physiopathology of COVID-19 pulmonary infection. Usually it begins by interstitial lung injury, then hypoxemia occurs, then the patient self-injure his lung, and finally the parenchymal lung injury occurs. And these three steps are very important. Interstitial lung injury beginnings with all the physiopathology described in my slide, intense hypoxemia, which can be intense, then the patient self-injure his lung due to negative inspiratory pressure and very large transpulmonary pressure. And finally, a very strong illness occurs in all the parenchyma of the lung, and it's called the parenchymal lung injury. Next slide. If we go to treatment of this pathology, you can see that there are some therapy: virucide, anticoagulants, corticoids, anti-inflammatory, bronchodilators, and sometimes when parenchymal injury is too important, we have to sedate, paralyze, and mechanically ventilate the patient after tracheal intubation. And we need to give them antibiotics. But the most important thing I would like to express you is that we can break the vicious circle that promote from interstitial lung injury to parenchymal lung injury, and we can break this vicious circle by using oxygenotherapy. Next slide, please. And this is the major steps: interstitial lung injury, severe hypoxemia. Usually the patient at this step are present hypocarbia or normal carbia, then occur the self-induced lung injury, and finally it ends by tracheal intubation when the patient has parenchymal lung injury. Next steps. So this is the place we place oxygenotherapy to break the vicious circles. Interstitial lung injury occurs sometimes without any symptoms. We discovered this pathology when making systematically CT scan to the patient. Hypoxemia, it's a standard for this patient with lung infection. They become very quickly hypoxemic sometimes. We need to give them oxygenotherapy to limit the risk of self-induced lung injury or parenchymal lung injury. Next step, please. So we decided there would be 4 major basic specifications for the ideal device to give oxygen to these patients that are not sedated, they are fully conscious, and they need high flow oxygen, high peak flow system. They need a pressurized expiration to treat pulmonary edema and shunt, and they need inspiration pressurized to limit ventilation fatigue. So we need 4 things: high flow oxygen, high peak flow device, pressurized expiration, which can be obtained by PEP, PIP, or CPAP, and to limit ventilatory fatigue, diaphragmatic fatigue, or accessory inspiratory muscle fatigue by pressurizing inspiration using IPAP or BPAP. Next slide. So these are the different available systems to pressurize oxygenation. We can pressurize only inspiration, IPAP on the left. Then we can pressurize expiration, this is PEP or PIP. We can pressurize both inspiration and expiration, this BPAP. We can have a continuous pressure during inspiration and expiration, is CPAP. And finally, we have some particular interest for B-level PAPE, which means that for 4 respiratory cycles, there will be a continuous pressure. Then this pressure will be increased for the next 4th respiratory cycle. and then decrease to initial B-level PAP. These are the way we can pressurize oxygen, and patients need oxygen and pressurizing the airway. Next step. So which of these machine or device complies with our basic specification? We decide ICU ventilators, perfect. Operating room ventilator, perfect. Transport ventilation, okay. OptiFlow, okay. But we have also some pocket device that are doing very well. Next slide. All of these devices complies with the 4 basic specifications we define. Next slide. So based on this, we try to define the major specification for ward use. And these are the specifications we use in Paris, but we defined before. Perfect tolerance. The patient is not sedated. He must wear his mask and be comfortable with this. It must be safe. And we describe an open system, which means that when the system is open, there's never overpressure, there's never leak on the mask. It must be safe for the caregivers, which means that some oxygen devices are delivering so massive flow of oxygen that some droplets may drop out when they are breathing. When you put the OptiFlow, you have 60 liters in the pharynx. This oxygen is not inspired, so it goes out the pharynx, and this is droplet production with infected virus in these droplets. So the system has to be safe for caregivers and for the environment of the patient. It has to be easy to assemble, no sophisticated setting. It has to be strictly portable. It has to permit the patient to mobilize. It can be installed or reinstalled by the patient himself. And it is light to wear on the face and usable in all positions, awake or sleeping, prone, lateral, but also sitting in a chair. So the patient has to be quite mobile and can be able to wear his system during the treatment, oxygen treatment. And in the context of Solid 19, which is a humanitarian association we try to set, we have had some specification. It has to be cheap. It has to be light and portable. It has to work with pressurized air and not only with oxygen. And finally, it needs to have a limited oxygen consumption. Next slide, please. So we analyzed all the device we had. All of them were fitting basic specification, but only one complied with the major ward use specification. It called the CPAP of Boussignac. It's a very high flow oxygen system. It use 3, 6, 9, 12, 15, 20, 25, 30 liters by minute. It has a very high peak flow. I think it's the highest peak flow on the market, even from ICU ventilator. We measure 270 liters per minute peak flow for this machine, maintaining a stable inspiratory pressure within the mask. We can pressurize expiration, 1 to 15 centimeters of water. We can pressurize expiration, 1 to 10 centimeters. It's perfectly tolerated. It's a full open system. You can put a pen in it, it still works. It is easy to assemble. It takes a few minutes to assemble. There's no learning curve to use it. It's a simple adjustment oxygen flow, titrated on respiratory rate and SpO2, and it is efficient, which means that it has been already validated in the literature. Thank you for your attention. Oh, excuse me, there's the last slide. It's our small experience in Paris, in France. In our hospital, Curie Institute it's an hospital, the biggest hospital in Paris for cancer treatment. And we have been protected during the COVID pandemic, because initially we were asked by the French health system to continue to treat cancer. And COVID patients were put in other hospitals of Paris. But at what time? The system told us, please, now you have to open your ICU. And we did this. And we opened the ICU to COVID-19 infected patient, non-cancer patient, which means that we were invited by such patient. And this is our experience. I calculate the days of exposition to COVID-19 patient. In the world, there had been, during the last month, 1,800 days with COVID patient. We created an oxygen requiring unit. It has been 240 days patient, 13% of the days were dedicated to this unit. We had an ICU, we had to intubate 6 or 8 of the patient, only 3% of the patient we received. And we had a very nice experience because none of the intubated patients that were treated the way I told you in the presentation before, with the CPAP of Boussignac, placed in sitting position, in prone position while sleeping, they can reinstall the CPAP on them. They can use it anytime you want, anytime they want, and they learn how to use it. And I would say we had no death to deplore with this experience, trying not to intubate the patient, rather use oxygen under pressure. And finally, we succeeded in our treatment with no death, although some patients were intubated for 9 patients were intubated for 10 to 16 days. The last patient went out on her feet of the ICU yesterday. Thank you for your attention.
Thank you, Gilles. Thank you. We can see that your expertise in respiratory and ventilatory physiopathology is a key competency area to explain the treatment of COVID-19 patients, excuse me. I'll tell it in French. So now we...
Joel, what we're going to, I'm sorry, Farid, what we're going to do is Adriana is going to introduce Pascal, who I think is not able to join from Benin because of connectivity issues, and I'm going to present his brief presentation. Adriana?
Okay.
Yes, thank you very much. Pascal is not able to, Soraya is not able to connect now, but he's working in the biomedical engineer, as biomedical engineer in the Ministry of Health in Benin. He has attended many workshops with WHO, and he's also been an expert in WHO expert consultations. He has been also a reviewer of innovative health technologies for the compendium, WHO compendium. So without any further ado, I will ask Tom if he could please let us, if he could present Pascal's presentation, because he's unable to join us by internet right now. But,
thank you, Adriana.
So thank you.
For all of these sessions, we have dress rehearsals, and Pascal was very involved. And so you see, he wanted to give a snapshot of the case of Benin. Next slide, please. And basically, the story he's telling is that it's early in the buildup of patients, but as we all expect, there's a wave of patients coming to many countries in Africa right now, and we're anticipating that and trying to help work with that. You see, there is a very steep rise in cases most recently. Next slide. And so far, there has not been major COVID-19 incidents, but they're expecting a lot more, and they want to do the best thing for patients. And as we've just heard, this approach that Dr. Donner has talked about is less invasive and more simple. And they also are lacking ventilators, so they want to do the right thing by these patients. Next slide. So he's given an overview of how CPAP helps clinically, and you've heard a story about that extremely well in the last few moments. So I'm going to pass to the next slide, please. So these are some of the devices they're planning on using as they experience these kinds of patients coming up, and maybe these can be of help to you. Next slide. So in closing, he sees in Benin, even though the wave has not hit there yet, they expect a CPAP to play a very important role. But here's some lingering questions he wants to leave for us is, you know, they want to be prepared with maintenance and training. They need oxygen. Concentrators, we talked about that last week. And will they have enough pulse oximetry? So we'll help them address that with Adriana. Okay, back to you, Joel.
Thank you, Tom. Maybe we could try to go to your questions, because you ask many questions on the QR that dashboard. Many of you ask question, and I think Professor Donner could answer this one. What is the oxygen percentage of used generally when you're making a CPAP treatment?
Can I answer right now?
Yeah.
Yes, it depends on the machine. If we have machine, we titrate oxygen concentration to arterial saturation. So this is the way we do. These patients are not sedated. Most of them, they are breathing. They try to breathe, and we adapt the concentration of oxygen, the flow of oxygen, because if you have a respirator or ventilator, you can adapt the concentration because it's monitored in the machine. But if we have a CPAP system like the Bussignac system, we just monitor the flow and we adapt the flow of the system, which means when you increase the flow, you increase the pressure, and we adapt the flow to SpO2. Our objective initially was to maintain SpO2 above 90%, and finally we decided maintaining SpO2 above 85 and not pushing too much oxygen into the patient. We try to limit patients who are needing oxygen, but sometimes too much oxygen may be deleterious for the patient. So we titrate to obtain 85 to 90% oxygen. And each time we reach this objective, we try to lower the flow of oxygen in order to test the patient and to know where is it in the stage of illness.
Okay. One of our question, I think, but what is also really important with CPAP is, as you said when we prepare the meeting, is that when you use CPAP and non-invasive ventilation, what you want to do is to avoid tracheotomy or to avoid intubation. You try to avoid intubation because it could be worse for the patient. It could be maybe 15 days, 15 days more of 15 days of treatment.
Yes, what we observe that when you decide to intubate your patient, because some of my colleagues were intubated very early initially, and finally learning from Italy and China probably, we decided try not to intubate too quickly. And we proposed the patient to give the patient pressure and oxygen before tracheal intubation, because when you are tracheal intubated, usually you worsen your lung. Mechanical ventilation, positive pressure ventilation alters the lung, create inflammation of the lung. It has been demonstrated 25 years ago. Too much oxygen alters the lung. So when we decide to anesthetize the patient, paralyze the patient, intubate the patient, put it in prone position, we are increasing, we are majoring the inflammation of the lung. And probably, although we treat the patient, it gives us the time to treat the patient, to give antibiotics, to give different type of medication to the patient, anticoagulation. But we need, after this time, we have 1 week, up to 10 days mechanical ventilation. And then we have to win. And during this time of mechanical ventilation, the patient are sedated, no more, and they lose muscles. And it's very difficult to recover this muscle later on. So we have to try to customize them most of the time after 15 days. And then we have to win the patient. So decision to intubate the patient mean that you will have 10 to 15 days mechanical ventilation later. And this is a risky situation. Mortality in ICU when you are intubated is between 30 and 40%. We decided not intubating our patient, give them oxygen and pressure. And finally, we succeed in this strategy. We prevent, I am sure we prevent tracheal intubation, and we prevent dangerous tracheal intubation in some patients. Sometimes our patient needed tracheal intubation because they were agonic. So we decided they were tired. They were not anymore able to breathe. So we intubated them and we ventilate with the mechanical ventilation. But we try to make non-invasive ventilation as long as it was possible. And in our system, we had a system where we were able to detect this patient that would require oxygen. When they were requiring oxygen, we monitor them and give them pressure. And finally, most of them, I would say most of them, were weaned from oxygen and left the hospital without being intubated.
Thank you very much. We find Pascal. Pascal is back, and maybe he could actually. Tom did your presentation.
Yes. Any comments, Pascal? Yeah.
But it could be awesome to have your comment. Yeah.
Yes, because my comment just to tell people that question. My comment is question. Some questions.
Let's go with the question.
Is it possible now, because I know that you did my presentation, just to ask if it's possible, because in Africa we have oxygen problem with ventilator, with CPAP, we need oxygen. Is it possible to take care to coronavirus people with concentrator? Is it possible? Because in Benin, we don't have serious cases. You see in the presentation, we don't have serious cases. Our people, they are young. They are young people. We don't have like at Europe, like diabetes, old people. Then is it possible for us? Because with ventilator, you need to intubate patients. But how about concentrator? That is the first question. The second question, is it possible?
Pascal, let's hold that question. Second question, Adriana, do you want to respond or Gilles about the oxygen concentrator use? Either of you?
Maybe Abderrahim can respond to this question.
With the last device that presents Gilles on his presentation, the CPAP Buciniac, you can make it work without oxygen, just a mixture of air. If you have compressor, I think in Africa, air compressor are available. Although the oxygen is not a resource, is a rare resource. With compressor, you can make it because the CPAP of Buciniac operates to achieve two main objectives. The first one is to provide assistance to the patient's respiratory work, whether in the inspiratory and expiratory phase. And for that, she just needs to have a high flow gas supply, whether either if it's not oxygen. And you can, with the concentrator, increase the fraction of inspired oxygen by another access to the device. And you can, if you don't give a lot of oxygen to the patient, you will help him in the respiratory work. And this is the first indication for the COVID patients.
Okay, thank you.
I don't know if I was clear.
It's clear.
Okay.
Thank you very much, Farid. May I just add a little bit more of the answer of Farid? What is also really important is to put filter on your air compressor machine because you're gonna improve the pressure on the lung of the patient. And if the gas is not so clean, you can have also other problem. But it could be used only with air. That's right.
Yes.
Next question, Pascal.
Next question. Pascal, please. Yeah.
Pascal, you said that you have two questions.
No, I have question for Farid now.
Okay.
That compressor you talk about.
Yes.
Can the compressor give the patient oxygen or medical air.
It's it can work with ambient air.
Only ambient air. It's just
only
air.
ambient air. You just have to have the right pressure to operate.
Okay, thank you.
The air compressor is available for that, and you just supply with oxygen, because I joined the vicious circle that Jill was talking about before. The improvement of the respiratory work, as I said, contributes to a better oxygenation of the tissues with by a higher intake of oxygen from the ambient air, and the oxygenation of the tissues decrease the need of respiratory work. So it's the two elements are joined, and they stop the vicious circle that Jill was talking about before. Okay.
Yeah. Adriana, yes, tell us.
Yes, thank you. I just wanted, Pascal, for you and many of our colleagues from Sub-Saharan Africa, WHO is now procuring oxygen concentrators, but also PSA plants, and we're even thinking of our liquid oxygen to support all hospitals, COVID hospitals, so that they can get the oxygen, and that oxygen can stay forever, no? Because we know, and we are very aware of the lack of oxygen for surgery and for many other things. So that was the talk on Monday, but still it is in the catalog, and we're procuring it as WHO. So, and then what we want to do is do a match table between which ventilators or CPAP or whatever can be run with an oxygen concentrators and which cannot. And then, as Farid was saying, some run with compressors, others not. So we would like to do something like that to have a comparison table. We don't have it now, but maybe that's something, Tom, that we can put into the things to do. No? Over. I think there are many questions about if we use non-invasive or invasive ventilation. I think this is a clinical decision, but in reality, depending on the patient you have, and there were various questions saying only use one or only use the other. I don't think there is, so Gilles, you can respond to that, but it really depends on the patient, as you saw the clinical flow. And in WHO, please note that the clinical management is going to be updated in the next week. So as soon as we have it, we can send it to all of you. But right now we are considering both. Originally it was only invasive ventilation, and now we're considering both of them. That's why we put them as technical specifications, and WHO is procuring now CPAP, BiPAPs, and NASAL cannulas. Over. So that was just to respond to some of the questions, Joel, but I don't know if you want other questions to be answered.
Thank you, Adriana. I would just talk about another question that I saw, maybe talking about the aerosolization of the virus when you use non-invasive ventilation. As Gilles told us, it's really important to avoid the leak of the mask and try to have a mask. The sealing of the mask is really important. Maybe there is also a needed to add a filter. Maybe you could told us, Mr. Donor.
Yes, maybe I can tell about that. You're in mute, Jill. You're muting.
Yeah, that's it.
Can you hear me?
Yes. Yeah, that's perfect.
Yes, I could hear your question. I could hear your question. What we try many CPAP system, because we are talking about mechanical ventilation, which is sometimes invasive or not invasive, and invasive or not invasive depend on the device you put in the mouth of the patient. If you put a mask on the face, it's non-invasive. If you put a tracheal tube, it's invasive. So I think that during this pandemic, we try not to intubate, so not to make invasive ventilation, but rather to make non-invasive ventilation and to maintain non-invasive ventilation until the patient was weaned from this ventilation and will leave the hospital, or sometimes we need to intubate the patient. What I would say that if you have a ventilator, you can make non-invasive ventilation via face mask and you benefit from the filter of the ventilator. But if the pressure, if the patient is coughing, if the pressure of the mask increase too much, there will be leak, and this leak will contain aerosolized viral particles. When you use the CPAP, different device of CPAP, the Bousignac has had this particularity, always the Bousignac. I am sorry to tell you that Dr. Bousignac is sick right now. He has been infected by the virus, and I'm not sure he will survive. No, it's true. And it's so good. I know him, and I receive a letter from his family telling me that he was hospitalized and was in poor state. However, I would say his system is very clever. It's open, which means you can breathe and you can speak through it, and you can put a filter and then put the CPAP on the top of it, which means that you will be able to breathe safely and expire outside safely. There will, with this CPAP, which is not a ventilatory system, you can breathe spontaneously. It's open. You can put a pen in it. It's open. You can put a filter and the CPAP on the top of it, and you prevent any aerosolization. Since there's no pressure, there's a pressure defined by the CPAP, that there's no overpressure, always open. So we compare different systems, and clearly the system working with the filter are very important in this pandemic in order to prevent contamination on the environment of the patient and preventing also contamination of the caregivers. This is very important for us. And this is the reason in this hospital, we have all the system allowing to promote non-invasive ventilation. We select the Bousignac CPAP. Was I clear?
Yeah, sure. Maybe Adriana could add some stuff.
You're mute, Adriana.
You're mute.
You're mute.
You're mute. We can hear you, Adriana. We can hear you.
No, I was just looking into the question from Ehsan Bukola, which I think it is very important and links to all this one. What Ehsan is saying that maybe less than 5% of patients require ventilators, but they are not still enough. So I think it is something that the clinical doctors have to make a decision in the time, exactly following what Jill was saying. So when the patients arrive, they said, okay, which ones go for non-invasive ventilation and can benefit from that? And the ones that are really critical, that you have no other option, then you go to the invasive ventilation. But in reality, yes, Ehsan, you're totally correct. The idea is not to put into ventilation every patient. Depending on the situation of the patient, then you have to have different alternatives. Some of you are asking if only with a compressed air, with room air, like 21%, others with a higher percentage. That also depends on the patient. And the idea is that you always use your pulse oximeter. You need to have that all the time, because then you can measure, is the patient oxygenating or not? And then if not, you have to give him more. So you have to continue, you have to be able to monitor many parameters at the same time. So I just wanted to answer that, Joel, because I thought it was linked.
Yeah, sure. Do it.
Thank you.
Okay.
Yeah, as you said, it's really important to monitor. You said that the hemodynamic of the patient, then the oxygen saturation of the patient, but you have also to make the monitoration of the pressure of the CPAP. If it is too much, you could make an injuries of the lung, that's for sure. But most of the time, the pressure is not so high, and maybe you could tell us, Mr. Donner, is, like I said, is not so high. You're in mute system. Sorry.
Yes, Joel, if I can add something.
Yeah, do it.
Yes. The problem with this disease is really particular. The patient are becoming hypoxic, and the virus blunt the physiological response to hypoxemia. There is a mechanical system called the pulmonary vasoconstriction, hypoxic pulmonary vasoconstriction, which allows everybody to react to hypoxemia. But this patient have this system blocked, which means that they are hypoxemic. And we need to assist them, and we need to give them oxygen, because it's a treatment. Oxygen is not just to spend some time with pressure and to get wind from oxygen, but it's a medication. Oxygen is medication for this patient. Why? Because when you give oxygen to the patient, the drive, the inspiratory drive, which means the force to inspire, is less negative just because you give oxygen. If you give pressure to this patient, we thought that we could use pressure, only pressure air. If you got pressure, you improve the edema in the alveoli. So you increase the residual vital capacity, which means that you improve the oxygen store in the lungs. So if you give pressure and oxygen, you treat the patient, and they are less keen to alter their own lung trying to inspire, because when you try to inspire, you alter your alveolo-capillary membrane. And then when the alveolo-capillary membrane of the lung is destroyed, liquid flows out the alveoli, and it's edema, and it's a way to go to the tracheal tube and ventilation. So oxygen is the treatment, just like antibiotics, just like anticoagulants, just like bronchodilators. We give all these drugs to the patient, but oxygen is their medication. And their medication is oxygen plus pressure during expiration, and oxygen plus pressure during inspiration, which allows, because inspiratory pressure is diaphragm, is muscle. So you give the patient an option to breathe better, to have a better ventilation, because you improve, you decrease the work of breathing, you increase the force of the diaphragm because you use inspiratory, and then during expiration, you reopen the lung and let oxygen reach the alveoli and enter the arterial blood, which means that you decrease the negative pressure you do at each breath. Oxygen is a treatment for this patient, and oxygen allows some of them not to be intubated. Not all of them will be safe from intubation, but you can treat this patient with oxygen.
Joel, if you may, I would like to add something to your comment before about the interest of CPAP devices that do not require machine, and it's not mandatory to monitor the pressure with it, and furthermore, it's very single to drive, because you just have to set the flow rate of oxygen of mixture, like I said before, to drive the device. So it's although with the machine, the users will have to adjust adequate ventilatory parameters like the pressure, the volume, like you said. But in this case, you will not have. It's very easy to drive. That's the interest for the LMICs. Furthermore, it is cheap and it is easy to install.
Okay, thank you. Tom, let me just answer a few questions that I think it's really important, because
sure, go ahead.
Just in front of us, Menelik Dida from Ethiopia, he said that he has many CPAP machines, but for kids, for younger people, for an ICU. And he said, could we use this kind of machine to treat adult patients? I don't know, but I would say that depends the rate of the level of the flow of oxygen flow that they need, and depends the illness. Maybe the doctor could answer a little bit more.
Yes, and once again, I'm sorry. I will. If you have a machine, a ventilator, you can control the pressure. So you give the oxygen with inspired concentration. You can control, and you can control the pressure during breathing. This is one of the systems. But if you have no ventilator, let's use the CPAP of Boussignac. It's the open system. There's never overpressure. Never. If you have to, if the pressure is too high, as compared to the patient thoracic compliance. The air goes out the CPAP device. It's open, so there's never overpressure. It could be overpressure sometime when you close the system and you blow inside the system. You will see in my slide, I gave you some bench test of the CPAP of Boussignac. Boussignac system is surprising. High inspiratory flow and never overpressure unless you blow in it and you close the system, which means we have now a system. There are other pocket device CPAP that allows to perfectly set the maximum pressure in the airway. So they are safe. These are safe. But the CPAP for Boussignac, there's no fine tuning or anything. Just put oxygen, put pressure, depending on flow, adapt to SpO2. And when you have your SpO2, the patient is correct and the patient will breathe with this. And you have a point SpO2 flow. And we know exactly what this CPAP promotes in terms of expiratory pressure, depending on the flow. Regarding inspiratory pressure, it depends on the inspiratory flow of the patient. The more important is the inspiratory flow, the inspiratory drive of the patient, the lowest will be the pressure during inspiration. Although this system has a very high peak flow for inspiration.
Thank you, Jill. I think we have a question, if you may, Joel and Tom, maybe Adriana from one of the attendees. They said there is no recommendation from WHO for this type of device. May Adriana answer? For the device that does not
I think that's incorrect. I think there are recommendations. Go ahead, Adriana.
All the recommendations are there. The technical specifications are there for BiPAP, CPAP, and high-flow nasal cannula. The three of them are in the catalog. The three of them are in the technical specifications. I just placed the links in the website, in the chat, and also for the website, and also for the website, for the page of the clinical management, so that they can see exactly when to use the invasive and non-invasive ventilators. And these are going, just for any of the links in WHO, please know that as more evidence becomes available, then these keep changing. So always check the date. There were some from March, some from April, and now in May we will keep updating them. But yes, there are, all the specs are in the website. Thank you.
Thanks, Adriana. I knew that, but I just wanted you to precise it.
Yeah, it is there. I just sent it in the chat.
As we see, the time is running, and maybe we just have 5 minutes to conclude. I don't know if Tom, you want to conclude, or maybe.
Well, we're going to talk about the to-dos, but you know, there's a lot of great questions coming in. I've seen 25 on the Q&A tab and many more on the chat, and we're answering some of them. But Adriana, we can take time at the end on Friday to at our next town hall to take some time at the end to address more of these questions that we haven't been able to address today. So that's one comment. It
will be great, yes.
Adriana, you talked about one of the to-dos a moment ago, and I think that's helping WHO, you know, what this is a user experience network that we've talked about on other town halls related to oxygen concentrators and other things like that to help get the O2 systems out to Africa that you're concerned with right now? Okay.
Yes. What we really need to know is which of the ventilators or any of these non-invasive can run out of an oxygen concentrator, and then what are the requirements, so that then we can make sure that they manage. We're not being able to purchase all the oxygen concentrators that we need because they are not available in the market. So, but nevertheless, WHO has been finding other sources, and we are in the process of procuring a lot of oxygen concentrators that will go to the countries. BPAP and CPAP are not being purchased this week, but will be purchased very soon. We would like countries to fill in the survey of the availability of ventilators, CPAP, BiPAP, etc. in the website. I just sent the link to the medical devices sources, and there is a link there to be able to comply and submit your questions and availability and needs, so that then we can match the availability with the needs. But I want to take the time to thank very much AFIB. They have been great. And thank you very much, Tom, for organizing this meeting with
Thank you, Adriana.
FMB.
Thank you.
I'm looking forward to the next session. Thank you.
Thank you, everybody. Thank you,
everybody.
for joining us.
Bye.
And
Bye-bye.
please stay safe and remember a patient is at the end of everything we do.
Thank you, everybody. Bye-bye.
Thank you. Bye.
Thank you,
Thank you,
Kathy.
Pascal.
Thank you, bye-bye.
Kathy.
Thank you, Adriana. Thank you. Sorry
Thank
for
you,
waiting.
everybody. Thank you, Gilles. It was really interesting. Thank you,
Bye-bye.
Joel. Kathy.
Thank
Bye-bye.
you.
Thank you.
Thank you. Bye-bye. Thank you, Tom. Thank you, Kaliroy.
Yeah.
Thank you.
Thank you.
Bye.
Send your questions, and we hope that we will be responding to them. And also, they will be posted in WHO. And please help us disseminate this information. Thank you. Stay safe.
Thank you also.
Stay safe. Stay safe. Bye-bye. Bye-bye. See you.
Bye.